Sir, it's sharp 1 and we are live. So with all your due permission, shall we begin? Hello?
Yeah, tell me.
Yes, sir. So we are live now. With all your due permission, shall we begin?
Yeah, we shall.
Thank you so much, sir. Good afternoon, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he needs no introduction, but it's our pleasure and honor to introduce him at our forum. He is none other than the very renowned dermatologist, Professor Dr. Jayakar Thomas, sir. Sir is MD, DD, MNAMS, PhD, FADD, FIAD, FIAP, FRCP from Edinburgh, FRCP from Glasgow, FRCP from London, FRCP from Ireland, FRCP-CH, Professor and Head of the Department of Dermatology and Venereology at Balaji Medical University, Chennai. With Sir's wonderful experience and with his wonderful insights, we are going to talk about the topic of the day, which is the impact of psoriasis on the cardiometabolic system. So let us know more about the topic. Before moving on to today's topic, let's have a brief look on what the topic says. We'll be learning and exploring the fascinating connection between psoriasis and the cardiometabolic system. Psoriasis, a chronic skin condition, has been increasingly associated with various cardiometabolic conditions, including heart disease, diabetes, and more. In this live event, we aim to shed light on this important relationship and provide insights into its implication for those living with psoriasis. So to talk about this topic, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you very much for those nice words of introduction. My dear friends and viewers, good afternoon to all of you. This is a very important topic. Now, most of us go away with the impression that psoriasis is a skin disease. It is more than a skin disease, it's a systemic disorder. It's a systemic disorder, there's no doubt at all. And as we go down the presentation, you will understand the seriousness of what I'm trying to tell you. Now, everything will depend on the activity of the disease and the severity of the disease. Now, on the left, you will find a good number of lesions which show severity of the disease. All these are severity of the lesions. Whereas on the right, you find activity, particularly the formation of pustules, which goes by the name pustular psoriasis. Now, that's not going to be the topic of today. However, I thought it's necessary for us to bring this out. Now, psoriasis is a condition which is treated making use of topical agents and a number of systemic agents. A number of systemic agents have now come into the market. And they go through, the entire disease go through different formats. As you can see here, stable disease. That is very early disease, caught in an early stage and with inflammatory cells all within the epidermis, not moving here and there. Then we come to active disease, where you see that these inflammatory cells which were in the epidermis are beginning to fall down or spill over into the dermis, going in for immune cells. And finally, reactive disease. Different from active disease, reactive disease, xanthomatous psoriasis, where this is the point where neutrophils start moving into the epidermis from the dermis. And if you were to look at it from immunological point of view, from an innate immunity to adaptive immunity. So the patient is born with an innate immunity, can leave it in one particular stage. But then, because the treatment is not initiated early, the adaptive immunity takes over. And then comes the other comorbidities. Now, what are the other comorbidities? We shall see a list of them. But before that, it's worthwhile remembering psoriasis is a common chronic disorder. Now, in a busy dermatology practice, every third patient has got psoriasis. I'm not exaggerating at all. Any dermatologist in this group will agree with me. Every third patient is a psoriatic. Every second patient is a fungal infection, dermatophytosis. Now, this results from various clinical experimental studies which indicate that psoriasis is a complex, multifactorial disease with a genetic predisposition. That's very, very important. There's definitely a genetic aspect to the disease, and one has to be emphasizing this point to the patient. Very important, because patient keep on asking, where did I get the psoriasis? Where did I get the psoriasis? It's from your family. They need not have shown it clinically. It could have been subclinical. So there are a lot of things which we take into consideration. And when it comes to the counseling part of the patient, we have to make them understand that there is a strong genetic predisposition. Now, the next paragraph is very, very interesting. The biochemical basis for the pathogenesis of psoriasis can be attributed to both overexpression and underexpression of certain proteins in psoriatic lesions. So there are different forms of proteins. And these, some of them are overexpressed, some of them are underexpressed in individual lesions of psoriasis. Let's go further about these protein expressions. They can be classified as keratinocyte hyperproliferation. All the while they have been told the psoriasis is due to increased keratinocyte proliferation. But as much as the keratinocyte proliferation is increased, the differentiation is reduced. In other words, the basal cells are going up to become the stratum corneum. They go up very, very fast, but they don't really get differentiated into stratum corneum. That's why the nucleus, which is down, does not disappear as the cells go up. And that's what we call as parakeratosis. That's coming a little far away from the point, doesn't matter. Now, the success of treatment, my dear friends, of psoriasis with T cell depletion and anti-tumor necrosis factor explains the involvement of T cells and TNF-alpha in the pathogens of psoriasis. So all the while we are thinking, how does this keratinocyte proliferation take place so fast, and at the same time, abnormal keratinocyte differentiation? And it's all due to these two factors, anti-tumor necrosis factor, as well as, unless we attack this correctly, the T cell depletion is also there, which has to be attended to. Now, the ground reality is, maybe I try to start very optimistically. I don't want to finish it pessimistically. I want to be realistic and label psoriasis as an IMID, that is an immune-mediated inflammatory disease. This is the reality of psoriasis. So that brings a few questions to the minds of the audience, of the viewers, as well as people who are true dermatologists. Is psoriasis a cutaneous disease or systemic disease? There's so much of pathogenetic factors taking place. Is psoriasis a marker of underlying systemic disease? The third question is psoriasis a risk factor for systemic disease? And what are the potential mechanistic links between psoriasis and systemic comorbid conditions? Each and every question of this seems to be very, very relevant, not only from the academic point of view, but from practice point of view. When you see a patient of psoriasis, is it only cutaneous disease, or is he going in for, is he or she going in for systemic involvement also? Now let's see whether we are getting answers from the current literature or earlier literature. This psoriatic cutaneous disease, a systemic disease, has been shown that there is increasing awareness that psoriasis is more than skin deep, more than skin deep. Several recent reviews focused on the biomarkers, including the systemic dimensions of psoriasis and the aspect of comorbidity psoriasis shares with other chronic inflammatory diseases. Must believe, and I give you a list now, shortly, in the third or fourth slide from here. It might be difficult to believe, but it is the truth, nothing but the truth. Similarly, can it be a marker of underlying systemic disease? Yes, of course, I suppose. Surprisingly, myocardial infarction, that's what we're going to talk about today. Cardiometabolic syndrome, myocardial infarction, metabolic syndrome, other comorbidities associated, great risk, much higher risk of these conditions in psoriatics. This psoriasis is a risk factor for systemic disease. It is an independent risk factor. Independent risk factor for systemic disease, for diabetes, type 2 diabetes, and so many other conditions. In other words, if you look at, you go to a diabetes specialty hospital, every third diabetic patient will be having psoriasis. Now, when I say psoriasis, it doesn't mean the florid psoriasis or the scalp, elbow, knees, but there will be some small patches of psoriasis in every third individual. That's why about 20 years ago, sir, when I said that every third psoriatic patient will have diabetes and every third diabetic patient will have psoriasis, people are raising the eyebrows. The entire world kept quiet, but now they started believing the fact. Now they started believing the fact that when you see a patient with psoriasis or with diabetes, there is always an interlink between them. And that's why we say about the potential mechanistic links. So the immune-mediated inflammatory diseases may impact these comorbid conditions in a big way through shared genetic, environmental factors, a common inflammatory pathway. That's what the word shared is very important here. The shared. And look at it, how they are shared. Psoriasis with obesity. Psoriasis, singular risk factor for cardiovascular disease. Obesity, singular risk factor for cardiovascular disease. And between these two, they are shared. They're interrelated, interchangeable. Psoriatic can become obese, obese patients can become a psoriatic. Now, I'm not trying to put enough fright into the patients or to the diagnostician. The idea is one has to be careful and be ready to tap the panic button as soon as possible. Be ready, be ready. And here, as I told you, my dear friends, common systemic disease associated psoriasis. And unbelievably, the commonest is depression. The moment you tell a patient that he has psoriasis, totally depressed. The doctor has got psoriasis, totally depressed. That is number one. And then there are so many other conditions, particularly the bowel disease, celiac disease, irritable bowel syndrome, so many other autoimmune diseases, multi-organ failure, etc. This is just to give you some, it's not comprehensive at all, just to give you an idea. And even of this, what I've done is I've red flagged 4 conditions: diabetes, hypertension, cardiovascular disease, dyslipidemia, metabolic syndrome. Because that's what is the topic of the day. We're not going to all the other comorbid conditions that we're going to see, but only these 4. Now, age and gender has a greater risk from comorbid psoriasis. It has been evident. It has been evident from the beginning, and we have done a lot of studies to show that the female gender has more of the comorbidities. But that is when the psoriasis comes within 30 years or 40 years. But by the time the patient reaches 60 years, the cardiovascular problem is just the same as what would occur in general population. So what does it indicate to us? Don't wait. Start checking it even at an early age in the psoriatic and look at it very, very carefully. And then the last point is, seems that young female patients with severe psoriasis have a very high risk of cardiovascular disease. That is hurting. Young females having a higher risk of cardiovascular disease. Now, if you look at psoriasis as a human model for inflammation, I have underlined psoriasis associates a higher risk of cardiometabolic diseases, including a higher risk of myocardial infarctions compared to the general population. Now, that is unfair. A person who comes with a patch of psoriasis on the scalp or over the elbows should not be allowed to die of a cardiometabolic problem, because it has been estimated that these patients lose about 6 years of their lifespan. 6 years of lifespan is very, very valuable, a person in today's living standards. And as we go, I'll tell you how we are going to manage this. The psoriasis and the metabolic syndrome, I told you earlier, obesity, cardiovascular disease, all that which are associated with metabolic syndrome, the obesity of psoriasis, which is interchangeable, diabetes, insulin resistance, cardiovascular disease in the form of hypertension. Now, putting them together, look at this. I told you earlier, obesity, fat deposits such as visceral adipose tissue promote inflammatory changes. Hypertension, again, inflammatory mediators essential for initiation damage of end organ. Insulin resistance in the form of diabetes, dyslipidemia, all of them arrowed down to metabolic syndrome, dose-dependent increase in the risk of psoriasis, and finally in coronary artery disease. If you look at them one at a time, you cannot say that it's an equal distribution of all the four. Obesity is there, hypertension is there, dyslipidemia is there, insulin resistance is there with diabetes. You can't say because there are four, each of them are 25% risk factor. Not that way. It will be individual. It will be individual that we have to look into. Look at this. This is an interesting finding. The lymphokines are the cytokines. Tumor necrosis factor, IL-17, IL-1. IL-17 you'll learn is a very important psoriasis. Now, what happens in this? They act on the adipose tissue and mess up the endocrine system, leading on to endocrine dysfunction. Acts in the muscle and impaired glucose disposal. So the glucose disposal is impaired, it's going to accumulate in the blood. Acts on the pancreas, impaired beta cell function, so impaired insulin. Acts on the liver, reduced suppression of glucose production. Reduce suppression of glucose production. So all these will lead to diabetes. And when we were telling, I was shouting myself hoarse 20 years ago, the connection between diabetes and psoriasis, the entire world was very, very silent. Now they're all up and about jumping. Yes, one has to be careful. One has to be extra careful when dealing with diabetics. Please, or when dealing with psoriatic, please rule out early diabetes or well-established diabetes. And this is what we tend to call nowadays as the psoriatic march. It's not a new concept. It's been there for a while. But then is beginning to show its importance now. Obesity, psoriasis, smoking, alcohol. Now, this is one thing which I would like to impress upon. Smoking, alcohol, obesity, and increased blood pressure. They are all supposed to be surrogate factors in psoriasis. And when there is psoriasis with obesity, the systemic inflammation leading on to insulin resistance, leading on to endothelial dysfunction, leading on to atherosclerosis. Look at that. It's so simple to read and understand, but so complex when it comes to the patient who's going to end up with cardiovascular disease. That's why I thought this topic of cardiometabolic impact of psoriasis is very, very important. Now, in spite of our best efforts, 3 important questions remain, and they remain unanswered. Maybe, can we predict who will be at risk of developing comorbidity? How can we predict? Of course, the genetic link, if you get family history, good. Each and every patient should be investigated. Will early intervention with therapy help prevent the onset of these comorbidities? Yes. A big yes, a big yes. And will children with psoriasis grow to healthy adults if the parents take good care of them? Yes, again. These are some of the publications that my colleagues and I have put on comorbid conditions associated with psoriasis. Quite a good number of them. We have published several of them. Actually, we made them into books, which I shall show you later. Now, the combination, the genetic factor, the brother and the sister having psoriasis, the mother and the child having psoriasis. Obese individuals already had an attack and gone in for CABG. Just to show you examples. Now, we have one thing known as omics, science known informally, but still factually. Genomics, proteomics, metabolomics, metagenomics, and transcriptomics. Now, we are talking about metabolomics today. There's so many other omics-related functions that one has to look into when managing psoriasis. For example, the genome, the transcriptome, the proteome, metabome. Now, all these have to be looked into very, very carefully. Not that we can measure them, but then we can definitely measure them mentally, and put them in the place correctly at the correct time, as what you can see here. Now, the evidence, therefore, my dear friends, lies clinically, what we saw, biochemically, which we have published, genetically, which we saw pictures about, epigenetic factors, that is omics-based, and therapeutic. Now, what is this therapeutic? I have not touched so far. We'll look at that. So what should we be doing? You and I have got the responsibility now. We understand, we have discussed how serious psoriasis could end up in an individual. So what should we be doing? Explain to each and every patient that these risks exist. There are also implications for dermatologists because we need to direct appropriate investigation and involve the patient's family physician. That's what most dermatologists fail to do, but unfortunately, get the patient's family physician involved. If there is an arthritis, the rheumatologist involved, check the blood pressure. Don't say, I don't have the time. Particularly dermatologists say all this rubbish. Oh, we don't have the time. Why don't you have the time? If you don't have the time to check a person's blood pressure, lock down your OPD and go home. That's it, finish. This is simple. Preliminaries that we are taught in medical school as undergraduate students. Student patient comes, we find out, then put the BP cuff and check. How long does it take? Not even a minute. You have to do it for psoriatics particularly. Send the patient for lab investigations. And I would like to tell here that if the dermatologist does not want to get involved, send back the patient to the physician. There's no point. You want the patient, you want the fees, but you don't want to give the proper service. That's not fair at all. That's not fair at all. Maybe some dermatologists are thinking the patient feels, oh, why should we pay so much of investigations to the dermatologist? The patient does not feel it. I have more than 40 years of practice, dermatology practice experience. Never found the patient to grumble because I wanted to investigate. As I told you, I said only 6 years loss of life, but the reality is 12-year loss of life, 10 to 20-year loss of life. So many years of illness, we cannot afford to give this to our patients. Why should it? That too when the age of onset is early. 25 years, a 12-year loss of life. That's unfair, unfair. So much the patient could have earned and lived in the 12 years. So we should be able to do something to combat this decreased longevity. And that's where the comorbidities influence on treatment comes. If a person has hypertension, for example, no cyclosporine. Patient is obese, no methotrexate. The patient is dyslipidemic, no cyclosporine, no acid treatment. So what are we going to do? This is a spot where one starts thinking of biologics. A little expensive, no doubt at all, not little expensive, good, expensive drugs. But then we have to. The government hospital, all these are given free of charge, the biologics. So admit the patient. Yeah, I've come out of the government setup. But still I have friends in the government setup to whom I can refer and say, please take over this patient, give the biologics at the expense of the government. So we should be able to do that. So that's where biologics come to play an important and excellent role in the management of psoriasis and the comorbidities. Another thing is, now youngsters indulge in very bad habits, unhealthy lifestyle. They eat a lot of things. We have a lot of fast foods nowadays. And then very young people start taking up alcohol, smoking, no exercise, no proper diet. So these are some of the things, again, we have to check. So patients can reduce the risk for these diseases, but they seem to be doing the opposite. Why are you smoking? Oh, I'm very stressed because of my psoriasis. Rubbish again. We'll have to counsel them, spend a little more time for these types of patients and tell them the importance of giving up these bad habits and taking up healthy diet. So my dear friends, now is the time. Now is the time for what? It's a very interesting, super interesting time. It's very interesting that we have the convergence of all this new knowledge with all the new treatments. So much of newer drugs have come, and we have so much of newer knowledge now. Converge them, put them together. It's a great time to be involved and witness the transformation of psoriasis to psoriatic disease. That's the statement I made first. Psoriasis to psoriatic disease. And if we're able to stop this transformation, we are doing justice. Now is the super time to look at the future to have genetic and biomarkers. Because we have genetic and biomarkers, but then what happens is a little expensive, so we try to skip them. But if you're able to find them out, we can definitely prevent what I told you again and again, the premature death, and give psoriasis patients back the 10 to 12 years of life that they're losing. Isn't it our duties as doctors, as dermatologists, as physicians, whatever you want to call yourself, it is our duty to give back that. And when we know how to do it, if you do not know, it's all right. Now we will know how to do it and we'll do it correctly. So my dear friends, we have new data, we have new science, we have new directions, we have the concept that it is a newly developed or defined systemic illness. We have to take into consideration systemic treatment is earlier rather than later. Control, lifestyle modification holds the key in combating progress of psoriatic disease. Mild exercise, you don't want to become a very, very strong man and woman. Mild exercise, lifestyle modification, not often running to the fast foods. These are the two things, exercising and the diet, very, very important for psoriatics. So it's not just about adding years to the life, it's also about adding quality of life to the years, which is important. It's very difficult, it's very difficult. Only when we see a patient, we understand how difficult it is. So the message, I thought the message, this is taken every year by my colleagues and me, and now it's appropriately comes just 2 weeks before the World Psoriasis Day, which is fixed by International Federation as 29th October. Today is 13th, 29th October, and we always take this oath. We have the duty to see that every patient with psoriasis is helped to live his or her normal span of life in perfect health, not let them lose the 10 to 12 years of life. And that too, they should get that back in perfect health, in perfect health. So that is our duty when we know so much and we have talked so much. Therefore, my dear friends, we have to please look beyond the skin in psoriasis, not just look at the skin alone. Please look beyond the skin, and it's not difficult, it's not expensive, and the patients are always willing. Patients are always. With that, I would like to definitely show you some of the books that my colleague and I have edited. Remember, Closer Look at Psoriasis, Textbook of Psoriasis, Yearbook of Dermatology in Respect of Psoriasis. These are some of the collections of mine, apart from the publication that I showed you. These are 3 books. They're all available if you want. You can get them at Amazon, or you can go to JP directly, write to them, and they'll send it to you if you're interested. Otherwise, just at least know that a lot of work is being done. A lot of work is being done. We are breaking our heads. I particularly am interested in psoriasis and would like to do a lot of work more in psoriasis, but I don't know. My age is, of course, barring me from that. It doesn't matter. I've done my best, and it's time for me to say thank you very much, ladies and gentlemen. Thank you, IJCP, for this wonderful opportunity. See you guys some other day, some other topic. Bye-bye.
Thank you so much, sir. Thank you for your wonderful talk and for the enriching experience of your insights that you have shared with us today on our forum with your presentation. Thank you so much for that. We have received few questions from the participants, sir. If you allow, can we take those questions?
Yeah, why not? Of course.
Thank you so much, sir. I'll take up the first question that we have received, and the question is, what is the association between chronic stress-related neural activity with subclinical cardiovascular disease and psoriasis?
Now, little is known for us to talk about subclinical cardiovascular disease and depression. However, The first thing you go to a cardiologist and say, why did I get this? Oh, you got depression or you're terribly stressed. That's the first thing before they start searching for a cause. So that's the only relationship that we could think about. Rather than that, search for a cause, search for a cause. Otherwise, the first thing that they do is one antihypertensive, one lipid lowering agent, one flow fibrate, one blood thinner. But what is the cause? What is the cause, my dear friend? What is the cause? Check that out. And I have noticed that all, not any exception, all these myocardial infarctions and cardiovascular diseases have some other dermatologic problem, particularly psoriasis.
Thank you so much, sir. Thank you for answering that question. We will take up the next question that we have received. And the question is, what are the factors influencing cardiometabolic risk profile in patients with psoriasis? We have covered this in the talk. We have
Yes,
received this question. Yeah.
Told you about the proteins, huh? Told you about the proteins involved. We covered that there. First join late, I think.
Yes, most probably. Last question, sir, that we have received from our viewer. The question is, what are the new insights into pathogenesis of psoriasis?
Now, there are three things that one has to look into. Number one, as I told you, the hyperproliferation of the keratinocytes. Number two is, although there is hyperproliferation, there is decreased differentiation. And apart from these two, overexpression as well as underexpression of genetic factors which come to play. Those are the insightful factors that we have to keep in mind when we think about pathogenesis.
Thank you so much, sir. Thank you for answering that question. Thank you for answering all the questions and for your to all the viewers for their patient listening. Thank you for their ardent participation that they have shown by staying with us throughout the session and putting across the questions to us. So thank you to all of them. And with this, I would like to thank you, sir, for taking out your valuable time and for being here at our platform. So thank you so much, sir, for taking out your valuable time.
Thank you. Thank you.
And with this, we would like to conclude the session here for today. Until next time, so that we can see our viewers with some another interesting topic and with all your enriching experience that we hear from you, sir. Thank you, everyone. We are closing for the day.